Evening, sir. Thank you so much for such a kind introduction. And I request Dr. Deepak and Dr. Anurag, sir, to be on board so as to just clarify our doubts on this very interesting panel discussion of genetic testing in prostate cancer. I also request all the panelists, Dr. Shivshankar, Dr. Dipen, and Dr. Prakash, sir, and Dr. Puneet, sir, and Dr. Gaurav, and Dr. Nishant, to be on board. I hope all are there.
Yes, sir, we are there.
Yes, sir.
Yes, sir.
Yes, sir, we are.
Everyone is there. And I request, I again request Dr. Deepak and Dr. Anurag, sir, to be on board, please. So as we all are aware and very clearly been mentioned by...
Sir, we have to do the polling. Can we do it? Just one question.
I guess we can do it afterwards because we are already running.
Sure, sir. Sure. Fine, sir.
So as General B.M. Kapoor has very clearly mentioned in his opening address that prostate cancer accounts for lots of mortality and morbidity, and the treatment landscape of prostate cancer is rapidly evolving with the advent of much and more understanding of the molecular pathways which actually drive malignancies. So we are having quite a few therapies which have actually improved the outcomes in prostate cancer, though the optimal sequencing is yet to be evolved. So this is the first question: what is your preferred drug in choice in first-line metastatic castration-resistant prostate cancer? I would like to correctly forward the question that what are the factors which one consider while deciding the first-line therapy in metastatic CRPC? Dr. Shivshankar.
Good evening, sir. In first-line metastatic castrate-resistant prostate cancer, usually based on the data of multiple studies, they usually prefer, if you use a upfront docetaxel compared to hormonal therapy, there is a advantage. But definitely, as you said, we look at various factors like what is the tolerance of patient, what is the clinical status, what is the comorbidity, what is the burden of the disease, all this, what is the age, what is the fitness, PS, and what is the, looking at what is the molecular profile. We take all these into account while choosing a treatment option.
Yeah, very correctly said that prior therapies, the response, tolerability, as well as the extent of the disease, the symptoms associated with the disease, all these things are seen before we decide the choice of therapy in the first-line metastatic CRPC.
Can I add on, sir?
Yeah, please.
Sir, if the patient have more of a bony symptoms, then we possibly go for a docetaxel or something. If a patient is more of a high volume disease, then again is a candidate for docetaxel. And in a low volume disease, then we can go ahead with the Varatrol. And if the patient is not symptomatic, then we can go ahead with the Varatrol.
Yeah, that will be my next question. We are just discussing what are the factors. So you very correctly added one more factor, that yes, the extent and the site of the disease and the rapidity of the progression of the disease, as well as the patient, what symptoms patient is possessing, those are the factors which actually help us to decide between the androgen receptor pathway inhibitors or the chemotherapy. So, if suppose, Dr. Dipen, that if suppose we decide that because the patient is having very high tumor burden, rapidly progressive disease, and symptomatic, and we decide to give chemotherapy. So, what drug you will actually?
Yes, sir.
What drug actually you will select for the patient?
Sir, as with the availability of the data, I would like to go ahead with the docetaxel if I choose to have a chemotherapy for the CRPC patient, symptomatic or high volume disease, sir. So I would go for a docetaxel, sir.
Why not cabazitaxel?
Sir, cabazitaxel, as with the experience as well as the trial data, sir, tolerability issue is much more issue that are problematic with the cabazitaxel, sir.
Yeah, you were right that docetaxel is generally being considered as the first line of therapy, but there's a trial, Fastana trial, where it has been shown that cabazitaxel at 20 milligram per meter square when compared with the docetaxel has shown equivalent outcomes, and it was non-inferior, and also even the toxicity profile was also tolerable. Dr. Shivshankar, you want to add something onto that?
Sir, while choosing the chemotherapy arm, we also look at what are the previous treatment options he has received. Had he received a docetaxel already in an hormone sensitive setting, in that scenario, I will prefer cabazitaxel if the treatment-free interval is less than 1 year. Otherwise, given the patient experience, patient will be definitely much more experienced with a docetaxel than cabazitaxel. And also, if you look at the toxicity, yeah, docetaxel definitely is slightly more better tolerable than the cabazitaxel. From these 2 points, I prefer docetaxel. Otherwise, if already patient had received docetaxel recently, that is, in a hormone setting, then I'll go for cabazitaxel.
Fine. Yes. First of all, I would like to say that taxanes are the only drug which have shown the improved survival outcomes as far as chemotherapy is being considered. And the patients whom we are having a high burden symptomatic disease, where we are considering chemodocetaxel is the first choice, but there is a randomized phase 3 trial, Astana trial, which has shown non-inferiority of cabazitaxel. Also, it is found to be better in patients, elderly patients more than 65 years who have actually received prior RT, because the toxicity of neutropenia is less with cabazitaxel as compared to what is seen with the docetaxel. Puneet sir, I would just like to ask that in what setting you'll use these androgen receptor pathway inhibitors or androgen biosynthesis inhibitors in CRPC patients, sir?
Sir, actually, I'm not using it as of now because I'm urologist. I have little experience in this. I'll request someone else to answer on this. I've not much of experience in using this.
Deepak sir. Deepak sir, if...
Yeah, tell me.
Yes, sir. Sir,
Sorry.
what setting you will be much more comfortable to use these androgen receptor pathway inhibitors or androgen biosynthesis inhibitors?
Could you elaborate on the question? In CRPC,
yes,
is it first line that we are talking about?
Yes, sir. First line. First line.
First line. And the question is whether abiraterone first or dosi first, or we are talking about...
Yeah, whether these newer agent first or chemotherapy first.
I think this point has been well brought out about what is the patient's age, what is his comorbidities. And in a way that I look at it, that sometimes probably giving docetaxel first is a better option because the patient doesn't get younger with age. So considering the fact that probably at some time in the future, you might not be able to use docetaxel on this patient. And if he is fit enough, and that is the reason why I have a certain bias towards using docetaxel upfront. But having said that, most of the patients, when you discuss it with them, and this is an important decision, so patients seem to prefer a tablet compared to a injectable. The side effect profile of abiraterone as well as enzalutamide is better than docetaxel. So probably you end up using abiraterone or enzalutamide upfront rather than docetaxel.
So any choice between abiraterone and enzalutamide, what would you select?
I work in a managed care setting, and whichever is available is the one that the patient gets, frankly.
Okay. So fine. So this point is very well been understood that yes, patient with the high burden disease, patient with symptomatic disease, patient with rapidly progressive disease, patient with visceral disease, these patients are the ones which should be considered for chemotherapy. Docetaxel is the first drug which has been chosen by most of us, but yes, cabazitaxel do have the similar efficacy based on the phase 3 data. I would like to ask one by one to each and everyone that castrate-resistant prostate cancer, would you like to continue androgen deprivation therapy? Because here, most of the therapies you'll be adding, systemic therapies you'll be adding, except for enzalutamide, you have to give even steroids to these patients also, which also will lead to the poor quality of life later by bringing the decrease in bone mineral density, that muscle health and all, everything will decline with all these drugs. So would you are we having a very concrete data to continue androgen deprivation therapy even in CRPC patients? One by one, first let Dr. Shiv Shankar, followed by Dipen, then Deepak sir and Puneet sir.
Sir, if it is not a second generation androgen receptor antagonist like enzalutamide, then I'll continue with androgen deprivation therapy if it is abiraterone.
With the enzalutamide, you will not continue.
With enzalutamide, either I can continue or I may not, looking at the patient profile. But if it is abiraterone, definitely I'll continue.
Okay, Dipen?
Yes, sir. I would like to continue the ADT with both the options, sir, enzalutamide as well as the abiraterone.
Deepak sir?
Yeah, I would continue with ADT with both the drugs.
Okay, Puneet sir?
Sir, the data says it should be continued in all the patients. They still remain receptive to the ADT, so it should be given. It should always be given.
But do we have any concrete data, any randomized trial for continuing ADT in CRPC versus not continuing ADT?
They say receptors still remain sensitive to the ADT, so we should continue even in a resistant stage. That is what the consensus is.
Fine. Nishant and Gaurav, sorry, I just didn't ask anything because everything was going on chemotherapy and all. So would you continue ADT in patient with CRPC?
Yes, sir. We would like to continue with the ADT in a CRPC patient as advised by the medical oncologist.
Okay. So Nishant, any take?
I would like to concur with the rest, all the panelists. I would also like to continue with the hormonal agents.
Oh, yes. So, yes, though we don't have any concrete data of continuing ADT versus not continuing ADT, but there are certain analyses which have demonstrated an incremental benefit of around 6 months by continuing ADT. And castrate-resistant doesn't mean that the tumor has become independent of androgenic stimulation, because there is still overexpressions of enzymes involved in androgens which are being expressed or which are being found in the tumor cell itself apart from the adrenal and testis. So ADT has to be continued. That is a very common consensus in all the panelists. So what is now the very important question that we have quite a few drugs and few more will come, because we have a quite good understanding of the molecular pathways driving the tumor growth in prostate cancer and driving the androgenic stimulation. So we might have much more newer drug, newer androgen receptor pathway inhibitors. So, but what is the optimal sequencing of these drugs is still has to be evolved. So, like anyone of you would like to take that, how will you sequence the pattern of drugs in metastatic CRPC patients? Deepak sir.
Like I've said, I'd probably go with Dosi, followed by abiraterone, maybe put on enzalutamide, re-challenge with docetaxel, maybe later on cabazitaxel. By this time, probably MSI as well as BRCA would come into play.
Deepak sir, my observation, can't we start abiraterone first rather than docetaxel if the patient is asymptomatic?
Actually, speaking, yes, you are right. Technically, abiraterone can be started first. Studies and guidelines agree that they should be started first. But docetaxel is one of the drugs that has been shown to work even on re-challenge. So probably that is the reason why I am a little more biased over using chemotherapy upfront rather than keeping it. But you are absolutely right that abiraterone or enzalutamide, either of them can be started ahead of docetaxel.
Sir, in a low volume disease, shall we go ahead with the abiraterone rather than docetaxel?
Yeah, we should, I guess.
Okay.
Yeah.
So yes, Dr. Puneet and Dr. Deepak has clearly brought the topic that any these androgen receptor pathway inhibitors or androgen biosynthesis inhibitors, they all have data pre or post chemotherapy in castrate-resistant prostate cancer of improving survival outcomes, and any of the drugs can be given depending upon the tumor burden and how the patient is responding. But still, there will be around 1/3 of the patient who will not be responding to these androgen receptor pathway inhibitors. And also, though there are no randomized study, but there are phase 2 studies where it is being seen. There are retrospective studies where it is being seen that giving abiraterone before docetaxel or giving abiraterone before chemotherapy lead to actually decremental benefit, or you can say that it is detrimental based on these studies. But there's no like concrete evidence. But you can see these are the small studies which have even see the overall median overall survival when the docetaxel is being given first, and or when the abiraterone is given first followed by docetaxel. That is quite significantly reduced in the patient. Anyhow, but if the sequencing is being seen, so there's a flag study of around 600 patients where it is a retrospective study where the patients were being from the multiple centers were actually retrospectively analyzed, and it was being found that all the sequences are actually improving the survival outcome, but the best survival outcome is by chemo, then newer agents. So the chemo, then androgen receptor pathway inhibitors or androgen biosynthesis inhibitors. This sequence is giving the maximal benefit to the patients. So, and also that, as I said, that patients may 1/3 of the patient will not respond to these drugs, the newer agents, the newer hormonal agents, because of multiple reasons. There's among that one is splice mutant variant. But cabazitaxel still retains the activity in ARB7, means chemotherapy still retains the activity in such patients.
Sir, I would like to bring out one point the clarification on same. Generally, the literature says, even the Davida mentions ki, in high volume disease, I would prefer definitely, as rightly pointed out by you, use of taxanes. And why not androgen receptor, these NH hormonal agents? Reason, because second generation AR tend to result into the treatment the resistance in the tumor resistance, and it changes, it culminates into small cell etiology. Neuroendocrine differentiation occurs with use of second generation AR at a later stage. So in thinking that and extrapolating that data, I feel that docetaxel definitely has a preference in visceral crisis over enzalutamide and abiraterone.
Yeah, that's a point can be taken. So this is the very important thing which we want to discuss, and I want the help of Dr. Anurag. He has already said that who are the patients whom we need to do the genetic testing. First, I would like to ask Dr. Shivshankar, what molecular testing, only you tell that what are the molecular testing you would like to be done in a patient of prostate cancer, or in this case, metastatic castration-resistant prostate cancer?
Definitely, sir. As you said, I mean, like, what is our need? Based on that, we'll choose the molecular profile. If we are looking for a family screening, or whether we are looking for a treatment options. In CRPCs, definitely we are looking for a treatment options. Then we will include, since there is though Deepak Munaj sir has clearly brought out that though in the cohort B, the benefit is not very much evident, but guideline says that across all the HRR panel, olaparib is approved. So I'd like to do all the HRR genes in the CRPC setting. And also MSI has an agnostic approach across all the tumors. So I'll also include MSI testing in these patients.
And tumor mutation burden?
It is also again has got an agnostic approach.
Okay. So the molecular testing has to be done, like already Anurag sir has very clearly mentioned that which are the patients, like patient with high risk, very high risk metastatic locoregional or METs to the regional or non-regional lymph nodes, and metastatic castrate sensitive or metastatic castrate resistant. These are the patients, along with intermediate risk patients who are having intrarectal pathology, should be actually tested for the HRR or HRD. So why it is being done? Because at least 1 in 4 patients will have genomic alteration in the genes which are related to double-stranded DNA repair. And there is 1:1 split between the germline and somatic mutations in the genes related to HRR or homologous recombination repair. Means in every 2 patients which we detect to have mutant HRR panel genes or HRD positivity, 1 will be germline and 1 will be somatic. So this was very clearly been mentioned in the preceding trials or preceding talks also that what is the stage when you are supposed to do, though Anurag sir has very clearly mentioned these are the early driver mutations, so can be done at any time. But yes, the predictive information they can give us only in the metastatic setting only, because we are using the PARP inhibitor in metastatic setting. So what now actually the test result depends upon the site of the biopsy and the sample age and the tumor purity. So it has been seen in the various trials and the various studies that newly collected specimen tend to have higher rates of positivity for this HRR mutant genes rather than the archived samples. You can see that a higher prevalence of HRR gene alteration was found in metastatic tumors, that is 31.8 as compared to 27.2, though both can be actually tested, but the sample age after 5 years sample tends to have a lower quality, and thus the success rate might decrease with the time. And these are the bar diagrams which clearly say that the newly collected sample tend to help us detecting more and more positive alterations in HRR panel of genes, and also the metastatic samples might give us more positive rates than the primary sample. That can happen because the selective genetic cloning which can happen between the primary and the metastatic samples. So this, I would like Dr. Anurag to for the benefit of all the listeners to tell us that what's the algorithm what we should follow. As far as what my knowledge is, that we should go ahead with we can detect the mutation or the alteration in HRR either by directly detecting it as a germline or somatic or genomic alteration in BRCA1 or BRCA2 or HRR related genes, or by calculating the score, which is genomic scar score or genomic instability score, which is the score of tumor BRCA1 plus tumor BRCA2 plus loss of heterozygosity, telomeric allelic imbalance, and large state scale transitions. So these are the two things by which we can do. Yes, the second one, that HRD score, is valid only for the ovarian cancer. So Anurag sir, just I would request just to just repeat those lines, like how to actually we should go, how we should follow the algorithm for detecting these alterations in patients with metastatic C prostate.
Yeah, so I think at the time of a diagnosis, if you have a high risk, very high risk locoregional and metastatic cancer, that is the time when germline testing should be done, at least for BRCA2 and BRCA1. The germline testing should happen at the time of diagnosis. And if germline is positive, then it should be used for as a predictive biomarker if this patient turns out to be the unfortunate one who will have a metastatic disease later. And the germline testing should also be used as a pivot for doing the testing of the kindred of this index case. As far as the somatic testing, somatic or tumor testing is done, tumor testing, as you said earlier, and you showed that cartoon also, can be done at the time of development of metastasis or after the failure of the first line of therapy with the in the metastatic castration-resistant prostate cancer. Once you have that cancer, you can do it. There is the possibility that somatic mutation may fail because sometimes the DNA is extremely fragmented. And if you will see the original the report also, I think they were about 18-19% failure. So in those cases, you can use the liquid biopsy. Liquid biopsy in the PROFOUND study was found to have a sensitivity of 56 or 60%. The 70 or 79 or 78% cases yielded adequate DNA for testing. And of those, then again, 80% were found to have concordance or true positivity. So 56%, but there was another larger study where the concordances were higher. And I think that will also depend upon the platform. But in case you are unable to do somatic testing, and your liquid biopsy has also failed, and you have not done germline testing earlier, then you should do germline testing now, because still you will get about 12% of the cases instead of 23% of the cases. You will still get 12% of the cases who will respond to PARP inhibitors. And one more point, that BRCA2 is one gene where there are large genomic rearrangements, or what we call as big indels, and about 10% are big indels. So it will be appropriate that you should do what is known as a multiplex ligation probe amplification assay to look for big indels, at least in BRCA1 and BRCA2, because you can again get some cases who may be benefited by PARP inhibitors. If there's anything else you want to know, I shall.
So, sir, Anurag sir, can I ask one small question? What should be the re-biopsy site, sir? It should be the prostate, or it should be a lymph node, or a metastatic site? So
bone should be avoided. Rest it could be anything, because bone, because of the decalcification, the DNA does not. The DNA gets highly fragmented by the acidic decalcification solutions that we use. Apart from that, it can be anything. It can be any site.
Thank you so much, sir. Such a precious piece of advice. If anyone else wants to ask anything to sir, they can ask. So I have learned this, that we should do the somatic testing, and that is negative. We should do the liquid biopsy and the germline testing, and just MLPA has to be done because of the large indels for BRCA2, sir. Right, sir? Anything else, sir?
But that, I think that's enough from my side. If you have any query, I will be happy to answer.
Okay. So this is. So if asked to tailor a panel for homologous recombinant repair genes testing, which genes would you select for including in the panel? That sir has already actually mentioned that around 15 genes are there which can be actually selected, but as been shown in the trial, that the cohort B actually has not achieved that much benefit as compared to cohort A or the combined cohort A plus B. But still, in prostate cancer, olaparib is actually recommended for all the patients who have actually genetic alteration in HRR related genes. So this is the PROFOUND trial. Already Deepak sir has clearly mentioned about it. So I guess I will speak, and if any of the panelists want to make final comment, they are please welcome to do so. Dr. Deepak sir and Dr. Puneet sir, if you want to say anything, sir, you can please.
I think you have discussed it very nicely. Thank you so much.
Yes, Dubey sir, you discussed very nicely, sir. It was very detailed discussion, sir. Thank you, sir.
Thank you, sir. Shiv.
Sir, it was an excellent discussion. Very practical questions were addressed. Good discussion.
Deepen, Gaurav, and Nishant, anything to add?
Sir, it was thank you, sir, for excellent discussion as well as day-to-day practice helpful.
Thank you. Thank you all my panelists, especially Dr. and Dr. Anurag, whom I have requested, and they were not included in the panel, but even at the last moment, they have actually considered my request and were present on board. Thank you so much.
Thank you.
All my panelists. Thanks a lot.
Thank you. Thank you, Dr. Dubey and all the panelists for that wonderful discussion. I don't think any further concluding remarks are required because he has concluded very well. So now I hand over the session back to the organizers. Thank you.